Breathing is the most automatic thing we do. We don't think about it, we don't track it, we rarely question it until something feels off. You are constantly tired, you wake up unrefreshed, you struggle to focus, you blame stress, long working hours, traffic, screens, your routine test might come back normal. So you move on. But what if the problem isn't just the stress? Recent AIM study suggests that nearly 104 million Indians may be living with obstructive sleep apnea, and the vast majority do not even know about it. Add to that rising pollution levels, high pressure corporate work, irregular sleep cycles, and especially post COVID respiratory issues in cities like Hyderabad, and we may be facing a silent airway epidemic. Today's episode is about understanding that silent problem. Joining me is someone who has seen respiratory medicine evolve over 4 decades, a pulmonologist with 40 years of experience, a consultant to the armed forces, and someone who stood on the front line during the COVID crisis. It is my privilege to welcome Dr. Pradyut Waghray of Respire Airway Clinics. Dr. Pradyut, I just want to start with the most important issue that people are facing, especially in Hyderabad right now.
Yeah.
Like a lot of people, they just go to bed, they might sleep for 8 to 10 hours, but still they wake up unrefreshed. They're tired. But if they go for the normal blood check, most of the reports are normal. So what is the thing that they should be looking into?
Actually, these complaints have become very common nowadays in our day-to-day clinical practice as well. We are seeing more number of patients with these complaints. See, there is a condition called obstructive sleep apnea. What exactly happens we call it OSA, obstructive sleep apnea. What exactly happens in that is the pharyngeal muscles, that is the muscles which are concerned with keeping our upper airways open, they lose their tone in the night time when the patient goes to sleep, and then they fall on the windpipe. Once they fall on the windpipe, that gets choked, and that's how they get the snoring. Now, the link between snoring and waking up unrefreshed in the morning is once this obstruction occurs, repeatedly the patient is having a not so comfortable sleep. It's a fractionated sleep, what we call unrefreshing sleep, because he chokes, wakes up, chokes, wakes up, so that becomes unrefreshing sleep. So daytime he feels very dull and always lethargic and not finding to work. That's very commonly we are seeing nowadays. And the common cause, as I said, is OSA, and the common cause for OSA is again the rising incidence of obesities.
Okay.
That's one thing we see common.
So, like a lot of people think that, they might be getting sleep for 6 to 8 hours easily. And then they might not be aware that they're having this OSA, what you call obstructive sleep apnea. So, what is the one thing that they have to be aware to at least know that they're going through OSA?
It is of vital importance to talk to the bed partner, because the patient is not aware sometimes that he is snoring in the night. He doesn't know because he's sleeping.
Right.
So the bed partner will give you the history. I mean, the commonest complaints what they give is two things. One is excessive daytime sleepiness, and the other is snoring.
Okay.
And if these complaints are there, and if there are no local causes to explain, then you should investigate for the obstructive sleep apnea by doing a sleep study.
In just what are the local causes? So that
Local causes, for example, simply if you have a nasal obstruction or a deviated nasal septum or some allergies or cold which block your nose. So temporarily at that time you will be having snoring or not able to breathe freely and having a disturbed sleep. But once you correct this cause by simple nasal treatment, the entire problem may disappear. So that we should not mistake it for OSA. So if these patients continue to linger on with snoring without any obvious upper airway complaint, then you should investigate for a sleep apnea.
Okay, so now like the OSA, you said now it might be the snoring that might be causing it. And then you said the local issues here. If it is a cold, people will understand. If there is any obstruction, people understand. But if it is a deviated septum, a lot of people, it is tough for them to understand that no, my septum is deviated.
Yes.
So at that phase, how a patient should look? They should go to the ENT first, or they should come to pulmonology. How should even patient recognize the problem?
See, the symptom of OSA is seen by both the ENTs and the lung specialist. The ENT, if the patient visits ENT, he will be having predominantly a complaint of nasal obstruction. He will go to the ENT probably telling him that I'm unable to breathe one side of the nose, I'm feeling blocked, I'm getting stuffy nose. These are the usual complaints by which they go to ENT. ENT on examination will find out whether there is any upper airway narrowing or not, which will make them suspect OSA, and they will go for the diagnostic polysomnography or sleep study. If he goes to a pulmonologist, for example, he may go with the history of snoring, or rather, as I told you, the bed partner may complain that he is snoring. Other thing, what they complain is choking, and the patient also feels that suddenly he wakes up in with the sleep, he's choking, and then he feels to gasp some fresh air he wants. That's one other complaint we see. And if you ask me, one of the common complaints what we see in our day-to-day practice in this OSA patient, as I told you, snoring, excessive daytime sleepiness. Sometimes we see patients have more, they wake up in the night to pass urine more number of time. Then this is especially mistaken if he also has diabetes. And then many people we see with the forgetfulness. They forget things where they are keeping, and that's how they come to us, and we've picked up cases. Sometimes we see patients who are young patients with the impotence. That is one of the common complaints, and they are quite hesitant to come out of it. But if you ask them, then they come out of it, and that's one of the cause where we rule out OSA and improve the OSA. This will improve automatically.
Okay.
So these are the few complaints. Recently, I remember a case where this patient came with the severe gastric reflux.
Okay.
On treatment with various antacids, not improving. Then he, on deep questioning repeatedly, he said, yes, I have some snoring for a long time. People don't give importance to that. Yes, I have snoring. But then when I probed more, he said, yes, I wake up in the night. I have not a refreshing sleep. As you asked me, they feel very dull. He used to feel very dull in the daytime, which was affecting his work.
Right.
That was rising his stress and leading to worsening of his acidic content. Okay. So then we did a sleep study for him. This was found to be moderate sleep apnea. He was put on the the CPAP machine. Also, subsequently on examination, he was found to having irregular beats of the heart. So then he had a atrial fibrillation, which means irregular beating of the atrium part of the heart. Okay. So this was also linked to his OSA. So what I mean is, has such an important disease that not only snoring and daytime sleepiness which patients come to us, but these are the subtle things which, if you don't find a cause, try to look for OSA.
Okay.
So that is one thing which is important.
So on the same line of impotence that you said, like a lot of people think they might be going to the neurologist a lot of times, or just a general physician. But understanding that it might be related to OSA is something that normal people cannot even think of, right? So at what stage you think they should be thinking of OSA? They should just start from there, or are there any other ways that they should start looking at it?
If there are classical symptoms when the patient is presenting about snoring, daytime sleepiness, and excess urination, forgetfulness, early morning headache, lethargy, then you should investigate for the physician, whoever is seeing, should investigate for the obstructive sleep apnea. Now, if he lands up with a specialist, for example, if he goes to an endocrinologist, that is, sugar is not getting controlled, that is one clue that look for OSA, especially if he is obese. Okay. If he is going to a cardiologist, telling that his blood pressure is not getting controlled, he needs more and more of medications, then the cardiologist will doubt OSA and check for OSA. Similarly, as he asked you about the neurology, if he gets unexplained forgetfulness, or sometimes they may complain of fits-like symptoms, right, where if the neurologist will do an EEG, other things, he won't find a local cause, then he will think of OSA. Oh. So OSA patients can land up with any specialist, but most complaints, because the bed partner will complain about snoring, which is very common complaint. That's how most of them end up with either the ENT or with the pulmonologist.
Okay, got it. And the recent AIM study in 2023 that got published in the Journal of Sleep, they published a staggering number of 104 million Indians suffering from OSA, and just 50 to 20% of them are getting treated. The rest, 80 to 85%, are not even aware of it. So you are you're treating patients for the last 40 years. Yeah. So what would what is your suggestion, and then what is your thought on that publication?
It's a very important question and very important study also which was published, because statistically in India, almost about roughly 18 to 22% of males and almost 4 to 9% of females, especially in the urban areas where obesity is high, they are suffering from obstructive sleep apnea.
More males than
Females. And out of this chunk of the people, which amount to some million, which you
100
quoted, hardly few of them get actually investigated for sleep apnea. The reasons being, the first of all, at level 1, the patients by themselves are not aware. Thanks to social media, now this snoring and it has become so much publicized that people are slowly coming to us directly. Otherwise, snoring is taken, yeah, my father used to snore, my grandfather used to snore, so what?
And also the only misconception that if you're snoring, you're getting a good sleep.
Good sleep. When you are tired, you snore.
Yeah.
Then, so these are things. But now slowly we are seeing the people are getting more aware.
Okay.
But yes, you are right that most of them are still remain undiagnosed. And surprisingly, when they go to their physician as well, nobody asks the question of snoring. If you are coming with hypertension not controlled, you increase one more tablet.
Right.
But nobody is bothered to ask why it is not getting controlled. So that is important. Not only the patient, but the physician also should at least ask 2-3 questions: snoring, daytime sleepiness, excess urination, tiredness. That will give some clue.
Right.
And most of these patients have associated hypothyroidism. They in fact, when simple, we see many things in Hyderabad and these patients, neck circumference. If you now they say a lot of importance is given to neck circumference. If your neck circumference in males, they say if it is more than 37 centimeters and more in females more than 34 centimeters, then they are more prone to develop sleep apnea. So by simply doing a general examination, measuring the neck circumference, we can come to a diagnosis.
Okay. Yeah, I always heard of the hip.
Hip is there are so many hip, waist hip ratio, but this is the easiest part we can measure.
Okay.
So, and just as an outpatient, you can do these things. So that is one important thing.
Right. So, snoring has different stages, right? And it might be people might be snoring for some time, and then people might be snoring all the time. And then there is a range of, maybe a low level to the red flag level. So at what point someone has to treat it as, that is an emergency thing that they have to get it done?
See, it's again a very important point what you have raised here. Snoring, many people, if 100 people snore, for everybody may not have OSA, but every OSA will have the snoring. Okay. So that is like that. So for example, if the patient happens to snore only when he is having some night duty and come home and tired, he is okay the other day, other rest of the week he is okay, then we don't do much about it. But if his snoring is what we call as crescendo snoring, when he snores, but as the loudness increases gradually over a span of time, and the bed partner, gets, to the point of irritation. Okay, this is increasing every day and getting worse and worse. We call it crescendo snoring. That is one clue you must pick it up. And also, when there is no local cause to rule it out already, then you must think of OSA. So crescendo snoring is one. And then excessive daytime sleepiness. We have a questionnaire called Epworth Sleepiness Scale, in which we measure the, how many, they allot certain points. Do you sleep while watching television? Do you sleep while reading a newspaper? Do you sleep at the signals, traffic signals? Like that, we have certain questions, and if there is a certain cutoff mark is there for that. So these are some of the things what we can do in outpatient practice to think about and rule out obstructive sleep apnea. Those snoring and excessive daytime sleepiness, and right, as I said, nowadays impotence in young people. That is very commonly we see, because obesity has increased in young people for various reasons. So that is always we ask the patients. And most of them, they don't come out, but slowly they will tell us. So that's one you should doubt.
Okay. Yeah, I think impotence is the one thing that people should always remember this. So on the same sleep apnea line, a lot of people nowadays, especially I think after the post-COVID, the awareness of melatonin has become so much so that people are just buying 10 mg and then popping up without even prescription because they are available online. So, how do you look at people just taking melatonin without prescription?
I think it should not be given actually over the counter. That's what I feel is, first of all. And post-COVID, since you have brought that topic here, post-COVID weakness is what we have been seeing for a long time. And people have been popping vitamins like anything and still they remain weak.
Right.
The reason for post-COVID weakness was that the COVID virus affected the mitochondria of the cell. The mitochondria is the main powerhouse of the cell, which makes us work energetically. So that was getting affected by the COVID virus. So the vitamins will not help there, but the coenzyme Q is one which is rejuvenating the mitochondria again. So we have learned after the good paper, I think it was in BMJ at that time, where it made us learn that it's not the vitamins but the coenzyme Q, which actually improves the mitochondrial power and post-COVID weakness is reduced. Now coming back to your melatonin question, most people, as rightly said, they said we are tossing and tossing in the bed for 6 to 8 hours, but there is no proper sleep. Yeah. And they go on some tablet and they wake up late in the morning. That's all. It's not right. See, once you if you don't have a refreshing sleep, please go and check for OSA. But please tell your physician and then he will check for the obstructive sleep apnea. So unrefreshing sleep is one important thing rather than taking the tablets.
Okay. So it is not stress. They should be looking at OSA.
OSA, yes.
I think most of the people put this whole thing under the bucket of stress rather than the OSA, because OSA is such an pandemic right now, but no one is aware of.
Exactly. That's because you are not aware.
Yeah.
And then if they go to a physician also, they are not being checked for OSA.
Exactly.
So that's why they label it to stress and they
label it to stress and then just go do yoga or whatever it is and then you're going to get stress. But at the end of the day, patients are not getting the right solution and they're looking for elsewhere. And I think that's where the melatonin or the nowadays the magnesium triazonate, all these things are popping up like anything.
Yes.
So do you like, how do you see the magnesium angle? Like, a lot of people are suggesting that take magnesium before sleep, you'll be getting good sleep.
No, magnesium glycinate is actually, if you ask me, that is one of the, doesn't induce any, it's not a sleeping tablet as such. It induces and calms down. It induces the normal sleep, they say, by calming down the mind. That's what the mechanism of the drug is. But it is not as I told you, if you take one magnesium, you will not go to sleep immediately.
Right.
So it is a form of propagating the sale of the drug, I'll say. But actually, you must look for the cause, why you are not sleeping, and then try to solve it.
Yeah. So the whole angle was coming from the stress angle, and then a lot of even the social media, as you said, a lot of influencers are pushing this magnesium glycinate, saying that take this, it will calm your nerves, and then you want to go to bed. So at least we cannot. As you said,
I'll tell you one example. One patient came to me with uncontrolled blood sugar.
Okay.
Every time rising, in popping more anti-diabetic medications. Then he saw, as you said, one of the YouTubes or the things, and then he said, no, your sugar is not controlled because you're not sleeping well. He sleeps only 4 hours of unrefreshing sleep. So he started popping magnesium tablets.
Okay.
Magnesium glycinate, 400 milligrams a day. He took it for some time. Sleep is not coming. Still, same thing. Sugars remain high. Then he went to the endocrinologist. Then from there, he was picked up. He had snoring. He had very unrefreshing sleep. His work-life balance was terrible.
Okay.
And he used to always be under stress, and see what happens in OSA. If you see, there are frequent awakenings. So whenever you are awake, it's like carrying a mobile in my phone. Suddenly you are thinking, ting, it drinks. And then you jerk and become. So that time your blood pressure rises, your cortisol level rises, so your blood sugar rises. All those bad things happen at that time. So this thing repeatedly is happening in the sleep in our OSA patients. So that is the cause of all these issues. And by simply popping magnesium is not going to solve. So that's why that endocrinologist picked up and started him for OSA, and then everything got settled off.
Okay, got it. So anyways, people are popping the magnesium. Yeah. So at least give us what is the mg levels that should be aware of.
Magnesium, the recommendation dose, if you need magnesium, you should check a magnesium levels. If they are low, you get 400 milligrams of magnesium tablets. You can take it, and then once your levels are normal, you can stop it. So it is not a tablet to be taken on and on, continuously on and off like that. It has certain indications.
Okay, got it. So 400 mg is the dose. So now I just asked you that question because nowadays it is available
Yes.
without prescription, and then no one is aware of whatever it is, and then someone is searching for Google, you'll get 10 different answers. So that's why, no, as a pulmonologist, use giving at least the dosage recommendations would be good. So at what point these respiratory issues or whatever the OSA issues become serious problems that goes to the lungs?
See, if you OSA affecting the lungs, if you remain as OSA patient, is he missed, if he is not being treated, for example, what will happen? His oxygen will come down.
Okay.
So he will get hypoxia. Hypoxia induced changes. What will low oxygen do? It will raise the pulmonary artery pressure in the heart. It will result in right heart failure. He will come with swelling of the feet, breathlessness.
Okay.
If his oxygen is low, his lungs will get affected. For example, if he is an asthmatic or any other lung issue, that will get worse. And by building up the carbon dioxide, patient becomes drowsy. He ends up in a NIV machine. Sometimes they even end up on a ventilator, if just by missing the main cause. Common things what we see in practice is patients requiring a NIV because of the low oxygen and high carbon dioxide, and also ending up with cardiologists with cardiac issues because they have missed the OSA. Blood pressure has gone up, sugar has gone up, he ended with a cardiac event.
Okay.
So subsequently he was diagnosed as OSA and retrospectively he was treated.
Got it. So, like someone who has been diagnosed with the OSA, what are the possible treatment solutions that are available?
OSA, first of all, the diagnosis. It is important to confirm the diagnosis, whether it is OSA or any other sleep disorder. There are many other sleep disorders as well, which can mimic OSA. One of them being obesity, hypoventilation syndrome, where patient is obese, we are seeing quite commonly now, and they hypoventilate, so they build up the carbon dioxide. They also snore, but then it should be differentiated from OSA. Now, coming to the diagnosis of OSA, if you ask me, there are what we call the gold standard is the polysomnography or the sleep studies. Now, the sleep study, the level 1, level 2, level 3. Level 1 is the ideal one, which is required. But then very, very rarely we do level 1 studies. The only indication for level 1 studies is because the person has to go to a regular sleep lab, sleep there, attended by a sleep technician, where all the teats of EEG, ECG, EMG, if all are connected, and they are done for those patients whom you are doubting OSA and those who have associated comorbid conditions like some heart condition is there or severe lung condition is there, so hypertension uncontrolled, so where he needs to be constantly monitored. That is level 1, which very, very less people they do it because it's quite expensive. Level 2 is the same thing without an attender. So generally what we do is the home study, home sleep apnea studies, which is level 3. Level 3 is sufficient to diagnose the routine obstructive sleep apneas. In that we measure the hypoxia, that is the oxygen saturation, the flow at the nose and the mouth, oronasal flow, the chest and the abdominal movements. These are all the basic requirements for diagnosing of OSA. And so we are preferring level 3 or home studies because patient is comfortably sleeping in his own home and the technician is going there, attaching the machine. Either he can stay there or he can come back home. If the patient is educated, they know how to put the lead when they go to the washroom. So level 3 or home sleep apnea studies are commonly done at present, practically speaking, to diagnose obstructive sleep apnea. Once you confirm obstructive sleep apnea, there are certain parameters called AHI, apnea hypopnea index. I won't go into all those technical details. Once you confirm obstructive sleep apnea, then we grade it. Is it mild, moderate, severe? And then we do another thing called CPAP trial, continuous positive airway pressure titration. That will tell us whether how much pressure the patient will be requiring with the CPAP machine. So depending on that, we plan his treatment. So first polysomnography and then he will go to the treatment part. Treatment part is commonly with the CPAP machine.
Got it. So, like if someone ended up with getting the CPAP machine, should that patient using that CPAP machine for lifetime or is it for a certain period of time? How does that management works?
Most patients, they require for a long time. If not lifelong, they will require for a long time. Because if you can find out some treatable cause, like as I said, commonly is obesity. If obesity is the root cause of his OSA and if he significantly is losing weight, improving his lifestyle modification, what we say, then he may get out of the CPAP machine. By and large, practically, they need for a very long time. Few people who do not respond to CPAP. We do a CPAP titration. If he is not responding, then these are the candidates who require for some sort of a surgical correction, which are very few, hardly 5% of people. And there are some recent things coming on, like mandibular advancement devices, where if people are having certain structural deformities in the mouth, then they can put this mandibular devices, advancement devices. They are usually made by trained dentists. And you can put it like a denture, and it gives you a more space between the maxilla and the mandible, so that the obstruction gets reduced. These are some of the things, but commonly CPAP is the one which is recommended.
Okay, got it. So most of the patients, whenever they get this recommendation of CPAP, they feel that their life, the quality of their sleep and then their life is obstructed because they have to carry that machine all the time. So how do that patients look at their CPAP machine so that it helps them?
You're very right. Not only in our country, but all over the world, the acceptance of CPAP is very, very low. People know the results are there to show that with the CPAP, a wonderful response. But then when it comes to actual usage of CPAP, acceptance is very low. So we have to tell them, we have to coax them. The family members have to support them. And once they start using for some days or weeks, once they see the benefits of CPAP, then they continue. Problem comes mostly young patients. Then they would, naturally, nobody would like to sleep with a mask and go.
Exactly.
There are certain new developments occurring where sublingual devices have come. They are all quite expensive and still in the experimental stages. So that's why we insist them to cut down the weight and see that you hopefully get out of this machine soon.
Okay. So the people suffering from OSA, like, what are the things that you recommend them, especially while they're traveling or especially while they have to go on outstation for a longer period of time? How should they manage it?
Actually, the CPAP machines now are being allowed in the airlines also, both in domestic as well as international. You can carry with you in the plane and you can use it wherever you go. If you have no objection to it. Some people don't want to carry it outside. So 1, 2 days, 3 days, if we can travel, we can avoid it. But by and large, if you go for a long vacation or something, it is ideal to carry the machine with you and use it in the night time.
So on the other side, a lot of people actually suffer heart attacks or any other major incidents while traveling. So is OSA related to those kind of incidents?
One of the common cause is OSA. Yes. I will not say all the causes of heart attacks are due to OSA, but common causes are OSA, because these are the undiagnosed causes. See, hypertension, diabetes, the awareness is so high among the population, and even the cardiologists, immediately they will pick it up and treat. So they are very, very unlikely unless the patient is grossly negligent. But OSA is one thing which is neither picked up by the patient nor by the physician. So yes, they are one of the common causes of cardiac events occurring anywhere rather, I'll say, and occurring mostly in the night time. We see many people he died in sleep. He had a heart attack and died in sleep. How do you know he has heart attack?
Right, exactly.
It is due to this. He had obstructive sleep apnea. He had severe. This morning only I saw one patient. He had 456 apneas, stoppage of breathing. 450 times stopped breathing in one night. Oxygen dropped down from 94 when he was awake. It came down to 31 during sleep. His heart rate is fluctuating from 34 to 194, like a pendulum. What more do you expect from him?
So can you please explain about that patient?
This patient is an obese lady who presented, actually referred to me for uncontrolled asthma. That's how I saw her. So asthma part, she recovered with change of medications. But then I also asked her, do you have anything? Because always you see when, for example, when your asthma is not improving or anything is not improving, look for some cause rather than increasing the dose and sending him away. So if you probe deeper and questions are asked, then they come out, yes, I have snoring. Husband says she wakes up in the night with choking. Now all the story has come out. She is gaining 10 kgs weight in 6 months' time. She was found to be hypothyroidism, which is commonly associated with OSA. And so all these things came out. Then we did the sleep study.
Okay.
And this is when the sleep study report came. Severe OSA is the AHI, what we say, apnea hypopnea index, normally should be 5. In her, it was 55.6. So severe apnea is there. And then we did the CPAP titration. She improved, I think she required some 10 centimeters of pressure. AHI improved to 0.4.
Okay.
So that's what I mean. If you make a diagnosis, and now the problem is coming with she doesn't want to use the mask.
Right.
I said your saturation is going to 31. Any day you can end up in a cardiac event. Imagine if the heart muscle is receiving only 31% toxin night tide. What else do you expect? They will develop arrhythmias, irregular heart rate, end up in some cardiac event. So then we had to tell her, cajole her, this is what you use for 1 month. Let us know how you feel, and then we will see. Okay, I told her. So slowly she will use it. I told her husband to see that she uses it regularly and let us know if anything non-compliance is there.
Okay. So you said use it for 1 month. So usually after how many days a patient will see the quality?
We say 1 month because they will see. See, when we do the CPAP titration, the next day they will feel better.
Oh, next
after
day.
Using the machine.
Okay.
She only says, I feel so better. I've never slept so well in my life.
Okay.
But that was only for 1 day because it was a test, part of the test.
Right.
That's what I told them. Now, 1 day you improve so much, you use it for long term.
Right.
And because these machines are quite expensive,
yes.
So we tell them to take the machine for rent for 1 month.
Okay.
Get used to it. So, and once they use for 2 or 3 weeks, they will feel better and they will more, their acceptance rate is high. Then they can purchase the same machine. Otherwise, they will waste the money. They just buy the machine and don't use it. It's a waste. So that's what I say practically. You use 1 month on rent and then you purchase the machine. So the acceptance is high and they continue to use it regularly.
Okay. So are there any tips that you can suggest to choose the type of the machine?
There are, the machine, if you see the machine, this is a small machine kept here. The problem occurs with the interface. When the mask comes, this is lying down on the bed.
Yeah.
Now, mask can be a full oronasal mask covering the mouth and the nose. It can be only a nasal mask also, or it can be only nasal pillows fitting into the nostrils. Okay. So it all depends on what your pressure requirements are. If your pressure requirements are very high, then you will require an oronasal mask, full mask. Like that. So many people who are having mild pressures, they may get over with simple nasal pillow. Doesn't interfere with anything. Just it's a small nasal pillow with a pipe at behind, and he will sleep like that. He can go to washroom, take it off, put it again. Very easy to use, rather than a full mask. So I tell them to first get the test done, know what pressure requirement are there. Then we can give you options regarding which one you prefer. And whichever they are comfortable then. So we normally what we do, we before purchase, we ask them to at least try various masks for a week. Nasal mask, oronasal mask, nasal pillows, and whichever you are comfortable, whichever is improving the parameters, and that we can continue long term.
Okay. So on the same line, I want to ask you, couple of more options. Nowadays, people are saying that, taping their mouth while sleeping. So I don't know. I feel like it is a dangerous thing to do. What do you say about it?
No, I have also seen many ads with some nasal clips.
Right, that was my second.
That is, I don't think they are the answers. They may just reduce the snoring, but they don't change the pathology.
Okay.
The pathology is not here. The pathology is here.
Right.
So this is only a symptom. What is telling us about what is happening inside. So that's of no use. Basically.
That's of no use at all. Got it.
So many people, they ask us.
Yes, because nowadays, even I'm looking at a lot of people putting that the strip kind of a thing on the nose and then taping the mouth.
See, if you see the pathology, very interesting. The tone of the muscle is lost. So even by using the CPAP, we are not treating the cause. The muscle tone is lost. We are putting a positive pressure and opening it.
Okay.
But why the muscle tone is lost, we have no answer. That's why there is no cure for OSA.
Okay.
Having said that, there was an article in BMJ long time back where there was a huge music instrument.
Okay.
I don't remember the name. Some big name was there. And by blowing that instrument, you are able to stimulate your pharyngeal muscles. And then the tone increases. So that person has proved by blowing that instrument regularly, you can actually get rid of OSA.
Okay.
Because the tone increases, it won't collapse anymore.
Okay.
So there are some physiotherapy exercises being developed with that in mind. So, but I am not a specialist in that. So maybe the physiotherapist can answer your question. But they are being developed. So physiotherapy maybe over a span of time will play a significant role in sleep apnea, apart from the usage of CPAP.
Okay. So I want to take a step back here. A moment ago, you were talking about dentist treating something in the mouth for the OSA. So I've seen a lot of people suffering from the TMJs, or the grinding of the teeth in the night. Like, do those people also suffering from OSA, or is totally different issue?
TMJ is a different condition altogether. What I meant was people with micrognathia, what I mean is if their space, if their jaw is protruded.
Okay.
Many people you see with the protruded jaws, micrognathia or microglossia. These people are anatomical deformities are there. They are born like that. You can't change it. So even if you put a CPAP for them, it may temporarily improve unless you correct the anatomical deformity.
Okay.
Either they end up in surgery, which is a major one, or those people can use the mandibular advancement devices, what I was telling you about.
Okay.
So that are made to order for that particular dimensions.
Oh.
And so once they use that in the night time, this gets more space, so that obstructing part is reduced. So that's called as mandibular advancement devices. They advance the mandible, which is this part of the cheek, lower part of the cheek, and that's how the opening gets bigger and the obstruction gets reduced. So that is select few people, not everyone.
Okay. Got it.
Those who have that anatomical deformity.
Right. So we were talking about the sleep test, right? So, like, what could be the difference between getting the test in a lab versus at home?
The lab test is the ideal one because you are being observed 24 hours by the technician there. Whether you are keeping the leads properly or not, whether you are pulling it off or not. These things are important. And then, so he will be constantly observing. And are you having any choking episodes, which are recorded very well. So that is the one where it is a completely observed, monitored, full sleep study where even the EEG leads are recorded. That is usually done for people who having some, for example, there's a condition called narcolepsy. If you want to differentiate between narcolepsy and this condition, then you need to use a full study with neurological EEG leads. But most of the respiratory and obstructive sleep apnea, what we are talking about, they don't require EEG leads most of the time. Sometimes they may require. So that is the difference between a level 1, which is the ideal sleep to be done, and a home study to be done.
Okay.
So with home study, as I told you, with the parameters what we use, we get evidence for obstructive sleep apnea. That is enough for us to diagnose.
Got it. So nowadays in Hyderabad, especially people working the night shifts, all the IT people, and also the lifestyle is like a lot of people are eating porehem biryanis and all. So what are the habits that at least you suggest for a good sleep?
I think the most important problem what we are facing now is both not only in the IT people, in the school going people as well, school going children as well, students as well. Obesity has increased because of eating of this fast food and junk foods.
Okay.
So many hotels have come, everything has come, and the earning capacity has increased. So they go on a binge on the weekends.
Right.
So that is not the right thing to do. You eat, but see that it's your body is getting affected.
Okay.
So I think weight is one thing, especially our waist circumference. That is what is in Indian people, that's what is actually making us more unhealthy.
Okay.
It is the increase in the waist circumference and the waist hip ratio. As I told you, the neck circumference. They did a study with the neck circumference and cardiac disease also. The higher than 37 made you more prone for cardiac disease as well. So to reduce this fat deposition, central fat deposition, that is important. So in other words, again, going back and cutting down fats, cutting down maida items, bakery items, cutting down most of these junk foods, cool drinks, contains lot of calories, ice creams.
Okay.
These are all the things. Eat it, but eat it within limits.
No.
And do exercise. That is important. Nowadays we see mostly children are busy with
the screens, all
the screens or the games, playing some video games. Nobody used to play. We used to play outside. Nobody used to plays anymore now. So I think we are having a lot of issue with childhood obesity, young people getting obese, getting diabetics, and if you see many people, they're going depression very fast. We get many patients who are hardly in their 30s and they look like as if they are in the 50s or 60s because of the mental as well as the physical deconditioning, I will say, what they've kept. And since you brought about the topic of the night shifts and day shifts, there are studies which show that if your sleep wake cycle, what you call, is disturbed continuously over a span of time, then the entire biological clock will get reversed and everything will go haywire. We are supposed to sleep at least 8 hours is the ideal sleep,
right,
where you should sleep. But being in medical field, I have not slept 8 hours so far for the last God knows so many years.
Okay.
But if you sleep, whatever you sleep, 6 hours, if it is a refreshing sleep,
yes,
that is what is important for you. So that when you wake up, you feel energetic.
Exactly.
So then that's okay.
Yeah. So like a lot of people are not aware of what is this sleep cycle hygiene.
Exactly.
Right? So can you please explain about that particular?
Yeah. See, sleep cycle hygiene again depends on, number one, it starts with the diet.
Okay.
For example, if you eat late in the night and if you eat a heavy food, there is no time to digest.
Right.
So obviously we'll be tossing and turning in the bed most of the time.
Yes.
So eat light.
Okay.
Dinner should be lightest. Sleep with at least 3 hours gap between the dinner and the bedtime.
Okay.
And do some light exercises after dinner. Not immediately after dinner, but at least 1 hour after dinner. Go for a short walk and then go to sleep. So that will give you enough time for digestion to occur and your sleep pattern will be reduced. Number 2, don't watch the WhatsApp and the mobile phone before going to bed, because that light on the phone will stimulate your rods and cones in the retina. It will stimulate your nervous system and you become more, you lose your sleep.
Okay.
So I will prefer switch off the phone before that, read a book or listen to a music, whichever relaxes you. You will get good amount of sleep. You don't have to go for magnesium pills or any other pills. And if you are used to it, if you are comfortable, do some meditation exercises. You will feel much better.
Okay. Got it. So you said a lot of young people are going through a depression and all, right? Before that, anxiety might be popping up. And then a lot of people who goes into that anxiety mode, they get into that hyperventilation and all. So how do they end up getting into the pulmonology care, or how do you see those kind of patients?
Actually, I will tell them, I will place them that they should consult their physician first.
Okay.
Because that's where the concept of family physician, which was there, now it's hardly lacking.
Yes.
So that's where the physician comes. Because these are not diseases to be treated. These are diseases to be corrected at that stage itself.
Okay.
You don't need medication for it. If, for example, if I see many people who a small amount of problem comes in life, they get depressed, they go to a psychiatrist, starting pills. If you go to a psychiatrist, they will give some pills.
Different.
So then you are stuck in that vicious
cycle of taking the pills
so rather than that, they should be taught about the how to keep themselves fit non-medically. Do yoga, exercises, eat reasonably less, and keep yourself fit, healthy. So these type of guidance, I think, is nowadays lacking, because specialists have no time. They will do some tests, write medicine, then you will go. So that's why the concept of their family physician, I think, should come up again.
Okay.
That's important. With that reason only, actually, I started the Waghray's Lung Foundation.
Okay.
Some time back, because I realized that I'm in this field for 40 years now. People come to me with diseases we treat.
Yes.
But that's not the answer. Nobody talks about prevention. So if you tell them how to prevent the disease, so that solves most of the problems. So that's how, with that concept, we started that Waghray Lung Foundation, where we used to conduct classes for patients as well as the GPs, general physicians, how to prevent lung diseases, vaccination, tuberculosis, asthma, all the COPDs, which commonly make the lung disease. And I find it quite useful, and I'm very happy with that response what I'm getting through the foundation.
Okay, got it. So Can you please tell me more about that foundation? What was the exact thought that when you got that thought of I need to have a foundation?
See, Waghray's Lung Foundation was started by me in, I think, 2005, 6, 8 years back, to be precise.
Okay, 8 years.
8 years back. And because we used to, I saw that again, no, people, they come with asthma, we write some inhalers, he will go, come back again. So that's not the answer. So unless you tell him what is causing his asthma. So then we actually used to have a counselor at that time with us.
Okay.
So that fellow used to go to a patient's house and see what are the allergens he is exposed to. And many times used to see that tap was leaking, fungus was there, and his dust was accumulated there. Everybody in our society wants to keep their house clean, throw the dust outside the gate. Okay. It's a common tendency in our country, unfortunately. So that was the concept. So that's how my person used to go and tell them, sir, this is the reason why he's having. He goes there, he will get exposed to that smell and have the asthma again.
Okay.
So what is the use?
Okay.
So like that brought me the idea. I don't have time because so many patients are there. We can't spend more than 10, 15, 20 minutes with him. Then I said, okay, this concept will start. So with that idea, actually that idea brought the concept of Waghray's Lung Foundations.
Okay.
So then we used to call patients, we used to conduct some asthma clubs like that. That's how it was started.
Okay.
So all the asthma patients used to come, we used to call them, arrange for some tea or biscuits. And I used to give a very short talk in that, not much. I wanted the patients to talk, how they are coping with their disease. So that brought out so many good answers from the patients themselves. Our counselor went and taught them, so they knew where they're getting the asthma from. They're getting it from the dirt source, avoid it.
Yes.
They are getting from that leaking tap, which was a source of the fungus. So they rectified that tap. Then we used to get patients about tuberculosis, how to prevent the spread of tuberculosis. So by cough etiquette, other things, regularly treating of tablets. So all these things, the patients used to come up with novel ideas. So that's how this Waghray's Lung Foundation was on.
Okay, perfect.
In this foundation, recently, I think about 1.5 years back, we started a program called Swasth Sambandhit Jan Sampark Abhiyan. What it means is health-related public platform. So my idea is to, before I retire at least, to create a platform which is free of charge, and so that the poorest to poor from India can consult a specialist through that platform online. And if I can offer 2 hours a week or something, maybe a cardiologist can offer 2 hours, neurologist can offer 2 hours. So in 1 year's time, we'll have a platform where all the specialists or super specialists are available to anyone through Waghray's Lung Foundation for free consultation. So that is my vision. So with this foundation, so let us hope how it comes to.
Yeah.
But this is how it started.
No, I got connected to whatever you said because a few days ago I was watching a Netflix show called House MD. And then that show is full of whatever you said. Like, those residents go to the patient's home, they check for all the sources of these issues. And then whenever you said, I got connected to that answer.
Because we see very commonly, we just increase the dose and send them back. So what is the use? Right. So with that, I thought we should start this.
And then I have never seen anyone doing that in India. And then whenever you said that, I really got connected to that. So final question, why airway clinics? Now, how does a patient should look into it?
See, actually, I want to go slightly back before the airway clinic concept came. Why I went into pulmonary medicine? When I was doing applying for my MD, I had a seat in cardiology, which was a very lucrative field at that time. At that time, at least. Cardiologist means you are a boom.
Right.
But then why I choose this field? So then I saw that many of the patients, who are having these lung diseases, they are from the lower strata. They are unable to, at that time when I was doing MD, there was hardly any hospital and need qualified doctors for lung diseases. MD physician used to see and treat for asthma. I remember I used to go to Usmania hospital, give Derifeli injection and come out. That's the only treatment available. So that actually gave us sort of a challenge and to go for this field. Anyway, we started and pulmonology started to grow. So that's how we lucky, I will say. But then having started this, we started actually with my clinic was very small in one room. It was called as Hyderabad Chest Center initially. Then we added the Triveni Medical Lab, my mother's name. And then we started the Hyderabad Radiology Center, one by one, step by step. And then after these three, we conglomerated into the Kunal Institute of Medical Specialties Private Limited. So this is the 25th year of that. 1999 we started. So then I was running the Kunal Institute for quite some time. Then I thought that most of the asthma patients, for example, if you take the asthma and allergic rhinitis, they are both together. If you see an asthma patient, 90% of them will have some upper airway symptom, sneezing, running nose, allergy, something. Similarly, if you go the reverse way, if you see any of the allergic rhinitis patients, they have associated asthma. So there are many such diseases like bronchiectasis in the lung, sinusitis in the upper airway, allergic rhinitis in the nose, asthma in the lower airway, COPD in the lung, sinusitis in the upper airway, like sleep apnea, both upper airway, lower airway. So upper airway and lower airway are actually, if you ask me, it should be a united airway disease. Upper airway, lower airway. God has made one. So we have divided into two, ENT and lung. So that gave me the concept of airway clinics as such, because most patients, 99% of them have both diseases. So if you can offer services of both upper and lower airways at the same place. So with that concept, I started this Respire Airway Clinics, which is a unit of the Kunal Institute of Medical Specialties Private Limited. We started this few years back. My daughter is an ENT, so she comes and look for the ENT. My son has done DM pulmonary medicine, so he is here. He specializes in intervention pulmonology. I am a pulmonologist since many years. So like that, the concept of the united airway or the airway clinics have started.
So this is the first of a kind in Hyderabad.
Yeah, I think so.
Yes. I think this is the most innovative way to treat patients for both upper airway and lower airway issues. If anyone has any kind of issues, we believe that you should be looking at the whole airway clinic rather than just segmenting it to ENT or pulmonology. Yeah. Is there anything else that you want to give message to an end patient who is looking for this kind of solutions?
I think if you have any of the respiratory issues like allergic disorders, especially because that's the commonest causes we see, and as you said, always think of the upper and the lower airway, because if most of them will have associated nasal and lower lungs symptoms as such. Similarly, in obstructive sleep apnea, since that topic we were discussing recently, there is a grading. What we see whenever we examine upper OSA patient, we always examine the neck first, rather than the lungs. Before sleep state, everything we examine the neck. One is for the circumference, and then in the throat we look for a score called Mallampatti score. That is the score where it tells us about the crowding of the structures in the lungs, grade 1, 2, 3, 4. So the more the grade, there's more the crowding in the neck, the more is the chances of the OSA. So that's that's where the upper and lower airway come together. We need an ENT opinion to look for the Mallampatti score. So if we have under one roof, the concerned specialists, the concerned investigations, and the concerned treatment, most of these cases can be managed in an outpatient with a lesser cost, so that inpatient is not required.
Yeah, not only lesser cost, but also the right diagnosis.
Right diagnosis. Exactly, you're right.
Yeah, perfect. Thank you. Thank you, Doctor, for this. It's your time, and I know your time is valuable. Thank you for spending.
Thank you so much. Thanks.